Hi, welcome to the Orthobiologics Podcast. I'm your host, Dr. Trevor Turner, MD, RMSK. Welcome to Season 2, Episode 1. Today, we're going to focus on when is this covered? So, in summary of this episode, we are joined here by Dr. David Crane. Dr. David Crane has tremendous expertise in orthobiologics. He and the rest of his affiliates have done over 45,000 procedures net to this point in time. He is primarily located in St. Louis and is the founder of Blue Tail Medical Group. He now has affiliates in over 7 states, including Arkansas, Missouri, Wisconsin, Minnesota, Florida, and Texas and Hawaii. And what we found is that his model is a very important one in the scheme, both of how orthobiologics is practiced, but also in the context of helping patients who work for a living, like most of our patients do, get funding for revolutionary procedures like these because their companies are turning to orthobiologics as a way to help both reduce their healthcare spend and to get better value and better outcomes over time. So thank you so much for joining us today, Dr. Crane. It's a pleasure to have you on the show and an honor. And please tell us more just about how you became passionate about orthobiologics and how you started pursuing the self-funded employer model for coverage of these very advanced procedures that you offer.
Well, thanks, Dr. Turner, for having me. It's really nice to be on the podcast, and I appreciate the information that you guys are giving out to patients and even employers and self-insured marketplace providers, because I think it's a big topic. I started back in 2004, and I had chronic pain like a lot of people do, mostly in my knee. And surgery wasn't a good option or help. I actually had surgery on my knee, which didn't really help the cartilage injury that I had behind my kneecap, which, as you know, pretty difficult place to get good cartilage growth and hard to get pain recovery. And so I had pain about 14 years and tried a lot of different things. And one of my mentors and I had heard about some of the orthobiologics coming out at that time back then. And that day, pretty much all we had was just platelet-rich plasma, kind of the early things, along with some prolotherapy, which is out there a long time. And for me, that helped and worked essentially for the last 14 years and has been a long-lasting, pain-reducing activity, letting me go back to activities that I want to do kind of every day kind of stuff, and long-distance running and things that I had been doing. So for me, the chronic pain was the driver, and the orthobiologics were a good fix. And we started using them for patients who had been through the entire toolkit that they had available in traditional orthopedics for things like, we started off mostly with things like tendon and ligament and kind of the soft tissue structures that were, causing pain. And then we've since gone on to really work on more difficult tissues like cartilage and intervertebral discs and other things. And certainly that's been a game changer from the perspective of what's available in our toolkits as orthopedic or non-operative orthopedic providers.
Yeah, and that's, I appreciate you sharing some of your personal story about it, because certainly people have different reasons and different sort of pathways in which they found it. And I think we see people who are trained in physical medicine and rehab, we see people trained in orthopedics, we see anesthesiologists, we see some rheumatologists, now who have really seemed to kind of take up the standard. But when somebody has had a personal experience, there's sort of no teacher for that. So that's
flying by the seat of your pants is always a little. It's a little scary in medicine when you're trying to come up with either a new technique or a new, treatment algorithm. A lot of us, as we all know, play with these things on ourselves to start off with, because as physicians, we don't want to offer those to our patients unless we've had experience with them for a while. So it really, luckily, we were very successful in helping the patients and using good protocols. And there's been a lot of publications now on the things that we treat the most, like osteoarthritis, and we're seeing more and more studies out there for discs and spine and those things that are the up and coming most expensive drivers of medicine. So I think there's a lot of use in this arena, which we're just beginning to scratch the surface of.
Sure. Yeah. So you raise a great question because we have patients who, didn't realize that orthobiologics was an option for them. And sometimes that's done in the context of making a surgery more successful. And sometimes it's done in the context of trying to avoid surgery and reduce their pain and have better function, like you just described. So, it's interesting because I always have, word of mouth is very important. And then some people are seeking us out, and we're trying to take more advantage, certainly, of the Atlanta airport, which is a busy one, to see patients here. But I just wanted to ask you, when you kind of break things down in terms of what maybe an individual seeks you out for your expertise versus some of the patients that you have started to see in the context of more of the kind of the self-insured employer plans, is it a difference, or is it kind of the same things as far as osteoarthritis and cartilage and tendon and ligament, or do you tend to treat certain things more than others?
Yeah, there's a few differences there. I think the most common thing we see in the sort of self-pay fee for service model is typically osteoarthritis, disc, and spine disease. Rotator cuff problems are also a really common thing that we tend to see in our clinic, just because most of the surgical treatments for both knee and orthopedics, they typically have about a 3-month recovery time. And we've had a lot shorter recovery time if we can capture those patients early on in their disease, if we catch them early in treating like knee arthritis or rotator cuff problems in our clinic. So, excuse me, on the self-insured side, a lot of those patients still have knee arthritis. A lot of them still have shoulder problems. But you're also getting into things like tennis elbow or plantar fasciitis or plantar fasciosis, some of the soft tissue things that can certainly be common in, settings where people are standing on concrete floors or standing all day or doing, a job function that requires repetitive use. And, I think there's somewhat of a different outcome sort of expected by the patient if they're fee for service versus if they're coming in a self-insured paid model. We always have wondered how motivated is the patient to want to get back to that job function as quick as they can.
Sure.
And I think that makes a big difference in the kind of in how patients select themselves.
Mm. Yeah, and that's a tough thing because obviously, part of what we're doing as we go to companies and say, let us offer you this option, this biologics option to perhaps, simultaneously reduce your orthopedic spend, but also to be able to increase both the efficacy and the time with which patients get treated and how quickly they get back to work and how well they go through rehab and how effective and productive they can then be at their job. We're capturing that data and we're tracking those metrics. So that's
Right.
definitely that's definitely something we want to be sensitive to. Now that you mentioned that, is there people look at different platforms kind of to do that, whether it's a mobile platform, a technology, or whether it's kind of self-administered patient outcome surveys. Is there an approach that you guys have taken to make sure that you are doing what it is that you need to do to prove to companies that you're helping their employees better or faster?
Yeah, we use two. We use two now. We used validated outcome scoring systems measurements. One is a surgical outcome scoring system called the SOS, which is a industry partner that we use that has that on a platform, but it's HIPAA compliant, and that data remains our own data. So that data isn't owned by any other companies. And then I also use another one, which is a functional outcome. I have a group that measures performance and movement patterns it's a combination of functional movement screens and selective functional movement assessments, as well as PRI. Most of those are, Gray Cook sponsored functional movement tools that are also validated scoring systems, meaning they've been checked across multiple population groups, and they've been shown to be, they say what they say kind of stuff. So we use that as well as just a pure functional, can the patient get back to doing the activities they want to do kind of outcome. And we do some self-reporting as well from patients, but most of that's captured in that surgical outcome scoring systems. And we can measure that across, an entire spectrum of other orthopedists in the country or across the globe.
Wow, that's great. So so you guys, for patients that don't know, some of those scoring systems that Dr. Crane is referring to can be certainly expensive to enroll in, but for the people that are serious about proving, their outcomes, then, they're going to spend the extra money and go the extra mile to contribute in such a way that you can say, look, I've got the data to prove that what I'm doing is extremely high quality and that it's making a difference. And I'm sure that makes a difference, Dr. Crane, when your group in Bluetail Medical is approaching a company and saying, look, not only are we confident that we're doing a good job for patients, but we've got the data, basically
Right.
to back it up. And I've seen that ownership of data has been kind of a critical thing, because we've had a couple groups actually approach us about joining their registries, but them saying, well, if you submit to us, then we own the data. And we're kind of like, well, that's
That's
defeats some of our goal.
we all know that data is the monetary system of the future. And unfortunately, the patients have to feel comfortable that their data is going to a secure site. And the physicians have to feel comfortable that what we're capturing is a true reflection of the outcomes, and that we can, help to drive that data stream, whether that's for us going to the FDA, which we do, and helping them figure out, ways to make this more, or at least keep the safety and standards as high as we can amongst all of our providers. And then also to be able to, honestly monetize that data down into the future as pharma and other agencies get into this. And I'm sure we'll get to that level when we start talking about payments in the future, how it can be covered. But, ultimately, there's going to have to be a delivery system for, the orthobiologics that are not only yours. Almost all the tissues that we use to treat patients are autologous, which means they come from that patient or that self. And, but as we get into the future and you have patients who have higher orders of disease and other things that we can't manage in just a clinic setting, then we have to go to the hospitals or to the bigger surgery centers for, you're going to be using other tissues that aren't the patient's own tissues. And there has to be some good data set that helps drive the responsible use, and also the business development that has to come behind that, because obviously nobody's going to pay for these if there's no money in it.
Yeah, so let me get back to, so you started to talk about monetization of data, and it's interesting to me to say that you really started doing this in 2004, because I think we've had prior episodes on the podcast where we've talked about, PRP's kind of been done in the United States since about the 90s, and talked about how we drew on some of the early literature, and some of that came from veterinary, some of it came from maybe even other parts of the world. And then, at least to my knowledge, the first stem cell injection, at least for knee arthritis in the United States, was done in 2005. So you're obviously kind of in that group of, what I would call pioneers, or, even innovators, sort of acting even before the early adopters would. So, to that end, I guess my question would be, is that when did your group, or you as the leader of that group, sort of feel that looking at the self-employed corporate model was the right way to go? And not only that, but that you had a significant value proposition to make, to where you could say, look, we have something to offer you that not only helps patients, but can also sort of help the reduce the healthcare spend of the economy, and ultimately help your company flourish as well.
Yeah, that's a great question. It that didn't come along until much later. Really from a self-funded group, really in 2018 is when we started to really look into that opportunity. Arkansas, as you guys, I don't know if you've covered this on the podcast in the previous episodes. Arkansas in 2017 was the first state to legislate an EASE Act for their state employees and teachers. And that really didn't get rolling until 2019. It took a long time to, it was honestly, there was a lot of politics involved, as you would expect there would be from a state program. Mm-hmm. There was a lot of special interests in different parts of the state that wanted to have, access, not access. And that took several years. But once we understood that states were looking in, because if states and the state employees had such a burden and they keep seeing their healthcare costs go up 20, 25%, whatever that number is every year, you have to offset those costs somehow. You can't keep escalating both the numbers of arthritis patients and the numbers of cases that are being performed. When we started looking into the data for knee replacements, for example, some of the numbers that I've seen say that the numbers of knee replacements are supposed to go up 673% by the year 2030. That's a lot of knee replacements. Yeah. That's a lot of titanium. And we don't have enough money in the system, quite frankly, to do it. So I think we really, once we got involved with doing a proposal for the state of Arkansas, which Bluetail did, and we have that state pilot. It's a pilot program that the state is running. Once we sort of got into that arena, we understood that the downstream versions of that were all the self-insured companies are going to have to find a way to offset the burgeoning costs of surgeries that they're getting into, whether that's spine surgery, which is obviously a huge problem in our society. From, spine surgeries are very expensive. And certainly some of the data on long-term outcomes for spine surgeries are problematic, and patients returning to work after spine surgery is problematic. So how do you keep a patient healthy and get them back to the job that they want to perform, to work at that, that job specifically, and that performance that they were used to before the injury? And how do you maintain that, that level of insurance for your employees? Certainly at Bluetail, we have we have not a large employee group, but we have, I would say a small employee group, and we provide health insurance, and that's getting harder and harder, as most of our small companies understand. And we feel obligated to do it, and we want to offer the best thing we can for those employees. And so for me, I feel like, they should have access to orthobiologics. We've seen too many good outcomes, and then it's another tool in our toolkit. It's not the only tool, obviously, that needs to be used. But I think in responsible hands with good decision-making for, right patient, right graft, right time, in the patient's disease process, it can be extremely helpful.
Yeah, and I would just echo, we're an independent group here. We've got about 200 employees if you, kind of count all the various parts of the value chain that we have and encompass here. We struggle with the same thing. I mean, we, obviously we cover health insurance for our employees. We feel that's essential for their well-being, and the initial kind of call we got from our insurance carrier was that it was going to be 30% more this year. And we kind of looked at each other and we're like,
it makes your eyebrows go up. Yeah.
Yeah. Because, we spend more time with these people than we do with our families. I mean, we care so much, about them and their well-being, and having a happy and healthy workplace. And so we, that's when we really kind of said, well, 200 employees, are we, at that point where we really need to start looking at self-insurance? And we got some competitive bids from some different companies to try and lower it. And, it got a little bit lower, but to be honest with you, I think that, as companies get to that size and larger, and I'll let you chime in on this, of course, as far as the size maybe of the corporation, but when they approach that level of size, the metrics and the economics really seem to make sense when it comes to self-insuring, because, frankly, there are companies and small businesses that are just going to have a hard time being able to keep up and offer health insurance for their employees if care continues to get more and more expensive. So.
Yeah, I mean, you have, if you have one sick individual in your pool and you're a small company with 50 employees, we're sitting around 50 employees for not very, we're not the size of Georgia Bone and Joint. But if you're sitting at, say 50 employees, and you have one or two employees who have a lot of need for medical care, that can drive your insurance cost really high, really fast. And so, We don't want to know who those employees are. We're not allowed to know who those employees are because of HIPAA laws, and that's okay. But it certainly makes it hard when you get to a year and, like you said, you have a rate increase of possibly 30%. And I think there is going to be, especially understanding on a self-insured company platform, say you're an industrial type setting, that makes a lot of sense for the most injuries that are going to happen in that industrial setting, that are, again, overuse or under recovery injuries, just sort of repetitive stress injuries, that orthobiologics should be in the toolkit.
Yeah, and we always, we've kind of talked about that on other episodes that, we have other avenues of care, which is, not limited to, but including typically, therapy, medication, injections that are not biologics, and then of course surgical outcomes, and some surgeries are less invasive than others. But do I've seen kind of some different numbers thrown out there as far as what you said in terms of the appropriate patient and the appropriate graft, given at the right time. And some people have thrown out kind of an 80% number, and it's pretty difficult without national data, to be able to look at that and say that's realistic to expect that biologics can offer, maybe that degree of success in lieu of other treatments, or maybe if other treatments have failed. I mean, do you think as an industry standard, is it appropriate to use a number like that when going with a self-insured employee plan, or is it not appropriate? I mean, how would you address that?
Yeah, I think it depends on the injury or the tissue that you're treating. In the in the rotator cuff world, if you have a partial rotator cuff tear, not a full thickness tear, not something that we know is surgical, we expect those outcomes at 5 years to be very, very good. Like their pain should be almost zero. Their function return should be almost 100%. So classically, we would like to see 80% on those, tendinopathies or soft tissue injuries that aren't bad arthritis or cartilage lesions. If you're getting into knee arthritis, then it really gets down to, a lot of factors. Certainly, smoking has always been one of the big ones, but also obesity or BMI. And then now we're trying to, take into account that waist hip ratio, because we know those patients can have a cardiometabolic risk. Those patients who have a lot of cardiometabolic risk for diabetes, certainly diabetes we know can affect some cellular responses, and that can be a problem in outcomes. And then you get down into the spine world and spine disease, and I'm happy if the patient gets 50% improvement in pain and function for chronic degenerative disc disease. So I think it really depends on the target organ that you're going after, the target problem. I think that tennis elbow, there's been a lot of studies on tennis elbow and those kind of things, plantar fasciitis or plantar fasciosis. Obviously we would think that those would respond a lot better. But again, if you look at the outcomes for some of those things, again, whether that's the return to work in chronic spine disease is abysmally low after surgery or fusion. And if I can get that patient to return to work and their pain is 50% better, can I keep them functioning? That's kind of the question you're asking. It's a very difficult formula, right? It's a difficult conversation that you have to have with both the patient and, you can't really have that conversation with the employer necessarily, but the employer has certain expectations if you bring them an opportunity like doing a self-insured program for orthobiologics in their company. And that's where I think that's where part of the rub lies, is how can you make sure that you are truly offering them the best return on their investment or pay.
Yeah, and I just appreciate what you said about the cardiometabolic disease, because we had a nurse practitioner, or excuse me, a nurse anesthetist who works with us, and he needed some treatment, and we treated him with biologics after he'd failed a lot of different knee procedures, and he's definitely doing better. But he kind of started looking at research and was asking about how to optimize cell yield and how to make platelets better and make stem cells better and all this. And so we kind of we had a discussion about what evidence or data there was or was not, and the conclusion that he had come to was, he said, I mean, basically all these things are just the things that you should be doing to be generally a healthy person. And I was like,
Right, right.
well, yeah, that's why a great primary care doctor is so essential and makes such a big difference. And your lifestyle choices are so important, to your overall
Right.
outcome. But, it was funny because the conclusion we came to that it wasn't just, a supplement or something that you took. It really had a lot more to do with, your nutrition and how you exercise and everything. But I'm going to shift gears for just a little bit. So when it's interesting when we talk about the way that healthcare has evolved in the United States. I like to kind of go back to some of the history, and I did a little bit of reading about World War II and how companies were trying to compete for workers at that time. And obviously, industrial jobs were essential during the war, and many of our men and women in the United States had helped in the war effort in different ways. But one of the things that FDR did was fix wage increases because of just the demands and the toll it took on production and the economy and everything. And so it seemed that companies at that time started offering health benefits basically as a almost as a perk to be more competitive in an environment in which wages were more or less fixed. So I found that to be very interesting because certainly people have the option to go to the exchange now, but it seems like the majority of patients that we see do get their health coverage from their employer. And so when
Right.
we talk about rising health costs in the United States, it almost comes full circle for us when we say, well, look, the companies that are savvy enough and smart enough and maybe courageous enough, if you wanted to use that word, or caring enough to consider, have the means to consider going to the self-funded platform, really are in a way sort of contributing to the solution of the healthcare crisis in the United States. Not that that one way is going to solve everything, certainly, um, but in my mind, it's almost like they set a historical precedent for how they guide healthcare, and now it's really fun to see big groups like Amazon and Berkshire Hathaway and J.P. Morgan and certainly others saying, look, we're going to use a lot of our resources as a global, even economic power to figure out how we, not only make healthcare safer, but also do so in a way that we're taking care of our employees in a way that's responsible and
Right.
financially more feasible. So um, can I ask, so you obviously are a physician, and, physicians in our minds also have to be sort of leaders or pioneers of the change that they want to see in medicine, or otherwise be condemned to be controlled by outside forces. So, um,
Yeah.
did you reach out to anyone else, or did you, partner with anyone as you were kind of trying to decide, hey, how do I learn basically to sit down with a company and understand uh, what they were looking for, or how did I learn to be more effective when trying to offer an option like this um, for companies that were in the market? How did you help figure that out?
We reached out to some of the people who were in that um, sort of benefits marketplace, and it's very different if you're going with, say, the state was a completely different animal than, say, a self-insured company. And I would say the self-insured companies are still very I would say there's a lot of interest out there. And like you were talking about earlier, I think they're all wanting to see good data and good outcome studies to really show that where they're going to, if they're going to put a program in place or a platform in place to offer this to their workers or our patients, um, they're really looking to make sure that like you said earlier, they care about their staff, they care about their employees, that they're not going to do something that's just A, going to get them hurt, or B, kick the can down the road. That's phrasing we've heard in the past. Um, but it's every single group that we've talked to has been a different conversation. So
Okay.
it's I don't think there's been one that's been the same.
So a lot of nuances across the board, sounds like.
Yeah, I think a lot of the companies that are open to it, to be quite honest, I think the either the owners or the founders or the prime drivers have had their own chronic problems, and they understand the limitations of what the current medical system can do, which we all, as physicians, we know there's a lot of things that we're great at in medicine as it stands today. And there's a lot of things that we're not great at in medicine as it stands today. And I think that a lot of things that are done, even in the orthopedic world, quite frankly, there's not a lot of good data around, or even in some sense, like corticosteroids for chronic arthritis pain. The data has proven that those are ineffectual or even potentially harmful. But that's still kind of the gold standard that we're being, we're using or being held to. So a lot of the discussions that happen with companies are just going back to even the older care systems that we've been using and sort of saying, well, that's not really the standard that we should be using. I think that's a very difficult education process when you're trying to say, even though viscosupplementation, for example, which I would consider a form of an orthobiologic, you're using a hyaluronic acid type preparation, which is a lubricant and a nutrition agent for the joints, for those of your audience who don't know about viscosupplementation. We use those in joints, and they were only really, studied for the knee to be paid for by insurance payers in the knee. But there's what's that?
I think in the U.S., yes.
In the U.S., good, yes. Yeah. But I think, a lot of insurances now won't pay for those anymore in the patient populations, or they spread it out so far that, it's almost an ineffectual use of the medicine. And, I think that there's a use for that, probably more so even than steroids in a lot of joint disease. I'm not a person who's, I'm not a don't ever use steroids. That's not our thing. I think in medicine, we have to do this push-pull between using something to shut the body's response off and something to turn the body's response on. And all we've ever understood in the past is trying to turn inflammation off. Like, we want to shut that response off. And so just getting that education out there to the employers and the patients that it's not just about turning the switches off. We can turn, we have to sometimes turn inflammation on to make a difference. I think that's a very difficult conversation to get people. Not only are you trying to get them to understand systems biology and now epigenomics, like you referred to earlier, it's our environment which turns those genes on and off. It's not the genes themselves. The cardiometabolic disease is a great example of that. And, if I want to be able to sort of use the levers to kind of, shut processes off or turn processes on. And I think that's where the biologics medicine, orthobiologics in particular, is going. And that's it's hard for physicians to understand, let alone, employers who are trying to decide, am I going to pay for this in my employees?
Yeah, absolutely. And that's why I think you find when we come together at national conferences, I think a lot of times not only are physicians talking with one another about what's working well, but a lot of times they're also spending times doing things or learning things that probably a PhD, would learn or do regularly. And we're in some sense, we're relying on them for partnership and collaboration to be able to make sure that we're holding the standard high and we're doing the right thing. But I can see why, from your point of view, if a subject is that dense or complicated, then it can be challenging to make that case with something that appears radical, to an employer who'd be looking at
Right.
expanding a program for a large number, of employees, patient,
Well, and going back to the data, the ownership of the data issue, like, we worked with a bunch of universities in the past, and some universities just want to get education to their PhD students or their candidates and their students. Some of those universities want that, what they call tech transfer. They want to own that technology. And that's a very hard proposition if you're trying to do research on, something that's a proprietary either matrix or something that we're using in a patient. Because that's one of the other big problems with getting this stuff monetized or paid for is that, I can't patent your cells. I can't patent my stem cells. We can't patent anybody's stem cells. And so that's where the big problem, really the biggest issue in this, is still politics and money. Unfortunately, we're still playing the politics and money game on how we're going to regulate and sort of where's the ownership lie for these cells. Because if I can't make a something that I can sell or transfer the technologies and the intellectual properties for, there's nobody that really wants to invest big money in it.
Yeah, certainly that changes the incentives for a lot of people otherwise who would fund projects like that on a larger scale. So,
Right.
Dr. Crane, I just want to thank you so much for taking your time to talk with us. Just one hand about your experience with orthobiologics and how you came to be an expert in the field, but also specifically kind of how it employs or how it relates to the self-funded corporate model, which we really feel is a standard that is going to be set for medical care in the future, especially as companies look to figure out ways to help take the best care of their orthopedic patients that they can. As we are closing up, do you want to leave us with anything? You want to leave us with your website or how patients can find Blue Tail Medical if they are looking for you or any of your affiliates to try and make sure that they get great care?
Yeah, thank you. We're at bluetailmedicalgroup.com, and you're welcome to, um, visit our site, and hopefully you'll find some great information there to give you at least a good education on what we offer and what we can do to help chronic or even somewhat uh, semi-chronic type, subacute, what we'd call subacute pain. So it's most of the time when patients are looking for options, we're still going to help them go through the regular pathways that traditional medicine has gone through, rest and early mobility for a lot of things, and all those types of rehab things that we've done for many, many years in medicine. So usually when patients are coming to our site, they're looking for specific information on regenerative medicine opportunities. So that's accessible for people at the bluetailmedicalgroup.com.
Great. Well, thank you so much. That'll wrap us up for today. Again, this was episode two, or excuse me, this was season two, episode one of the Orthobiologics podcast. And again, I'm your host, Trevor Turner, MD RMSK. This podcast is brought to you by Georgia Bone and Joint. You can check us out at georgiaboneandjoint.org or look us up on Facebook or LinkedIn. Thanks for your time.